Hello and welcome to Krok 2 2023 booklet. This exam was done on May 23rd, 2023. So we are going through the questions as a form of revision. So stay back and enjoy. If you have any question, let me know in the comment section and I'll do my best to answer you. All right. So for an intensive infusion therapy, a patient with acute respiratory failure underwent subclavian vein catheterization using Sedinger technique. For those of you who have been following my videos, I always tell you if they mention an organ system or when they start talking about a particular organ or a particular condition, start looking around that area. Now, this patient is having an acute respiratory failure. What it means is that everything that is going to happen in this patient is as a result of a complication of the condition. So we're looking at some possible complication of acute respiratory failure. But further investigation or further information will help us to navigate our answers. So let's continue with the presentation. Now, they said after administration of 600 ml of infusion solution, which is water, the condition sharply deteriorated. So after giving some fluids, the condition became worse. Tachypnea increased from 26 per minute to 40 per minute, meaning that the patient is increasingly having difficulty in breathing. Now, tidal volume has decreased from 400 to 250 ml. Auscultation detects sharply weakened respiration on the right. So what is happening in this patient is unilateral, meaning that it is happening at one side of the lungs or the respiratory system. Now the percussion detects dull sound. Dull sound. Anytime you hear of dull sound, it tells you that there is some form of fluid accumulation or some form of what consolidation in the lungs. Now, what condition has developed in this patient? So let's take our time and analyze every bit of this history or this question. Now, the question started by talking about what respiratory failure, which simply is a serious condition that makes it difficult to breathe on your own. Respiratory failure will develop when the lungs cannot get enough oxygen into the blood. Basically, that's what it is. All right. Now, from the history, a patient condition became worse after fluid administration, which tells us that we could be looking at either pulmonary edema or hydrothorax. Pulmonary edema or hydrothorax. So these are the two conditions we could be looking at for, or these are the possible complications we can't be expecting in this patient. So how then do we distinguish between these two? But before that, the question went on to say that the tidal volume has decreased. Tidal volume has decreased from 400 to 250. Now, when we talk about the tidal volume, we are simply referring to the amount of air that moves in or out of the lungs with each respiratory cycle. In a normal healthy male, you have about 500 mL, and in a female, you are talking about 400 mL. 400 mL. So that tells you that the surface area or the amount of air that is moving in and out has decreased, and that led to the tachypnea, that is breathing excessively or trying to breathe more so that more oxygen can come in for the patient. So back to our differential. So we have pulmonary edema and we have hydrothorax. Now, pulmonary edema is simply a condition that is caused by too much of fluid in the lungs. Too much of fluid in the lungs. Now, the fluid collects in many air sacs in the lungs, making it difficult to breathe. That's why I've brought this diagram here to help us understand this. Now, in a normal healthy alveoli, okay, or the lungs, air or oxygen comes in and carbon dioxide goes out. That is how it is at the capillary system or the capillary area, which is the alveoli. When fluid accumulates, it means that the surface area has reduced perfusion will be reduced, or exchange of gases will definitely decrease. So that is what pulmonary edema. But the interesting thing to know about pulmonary edema is that usually it is bilateral. Usually it is bilateral, meaning that it occurs at both sides of the lungs. At both sides of the lungs. That is pulmonary edema. So that is one difference you need to take home with. Now let's come to hydrothorax. Hydrothorax, as the name implies, it simply means what? There is what? Fluid within the pleural cavities. The pleural cavities. So there's a fluid collection in the pleural cavity. Now with hydrothorax, it is usually unilateral. Unilateral, meaning that it occurs at one side of the lungs. Occurs at one side of the lungs. Of course, sometimes it can be bilateral, but usually it is unilateral. All right, and that is why over here, per what we are discussing, yes, you can disagree or agree with me that we could be looking at what? A case of hydrothorax. Why? Because it is happening at one side of the lungs, even though pulmonary edema is also a very, very good differential. And some of my colleagues will might bring this argument out, but it is what it is. This is hydrothorax. So your answer here is A. All right, so let's move to this question. So we're having a 46-year-old man who came to a doctor with complaints of a rash on his hands that appeared 1 week ago and is accompanied by severe itching. Normally, skin rashes are very, very difficult to identify, so pay attention to this particular question so that it becomes easy for you. Now, the patient has a history of bronchial asthma and a seasonal allergies. So, what the condition you're going to be looking out for, you should know that it should be in a way linked with allergies. Because this patient has a history of bronchial asthma and allergies or seasonal allergies. So that is how to answer your question. So please put your mind across that. Physical examination detects a dry skin on the hands and multiple erythematous papules and vesicles with serous content, as well as areas of lichenification and excoriation. Now, on the back, that is on the back of both hands, what is the most likely diagnosis in this case? What is the most likely diagnosis in this case? So, first of all, what is lichenification? Lichenification is simply a secondary skin lesion that is characterized by hyperpigmentation, thickening of the skin, and exaggerated skin lines. Exaggerated skin lines. So this is what we are looking at. Now, these skin lesions usually appear from constant scratching or rubbing in areas such as the elbows. Very common in those areas. Very common in those areas. Now, before I move to the next picture, what we call excoriation. Excoriation is it's usually a mental illness, basically related to obsessive compulsive disorder. Obsessive compulsive disorder, also characterized by repeated picking at one's own skin, which results in areas of swollen or broken skin and causes significant disruption in somebody's life or in the person's life. So this patient has been scratching, and now he has developed what we call obsessive compulsive disorder. Okay, so that is not what we're looking at. We're looking at the history in totality to be able to make a very good diagnosis. Now, this picture that we're having over here is a typical example of what we call seborrheic dermatitis. Seborrheic dermatitis, which is simply a skin condition that affects the scalp. It causes scaly patches, inflamed skin, and stubborn dandruff. Stubborn dandruff. Many of you know what it is. That is, usually affects oily areas of the body, such as the face, the sides of the nose, eyebrows, ears, eyelids, and the chest. So these are the areas which get affected by what we call seborrheic dermatitis. So this is an example of it. Now we also called psoriasis. Psoriasis, which is simply a skin disorder that causes skin cells to multiply up to 10 times faster than normal. So that's the next diagram or the next picture you're looking at. They grow anywhere, but mostly appear on the scalp, the elbows, the knees, and the lower back. Now, there are many forms of psoriasis, all right, which you need to know. And I think there are some questions related to this. So when we get to those kind of questions, I will dive deeper for you to understand. Then we also have what we call the scabies. The scabies. This is a skin infestation caused by a mite known as Sarcoptes scabies. Sarcoptes scabies. It causes intense itching in the area where the mites burrow and a pimple-like rash appear. So that is what we are seeing in this particular diagram. And finally, we have what we call the atopic dermatitis, which is also known as eczema. Atopic dermatitis, which is also known as the eczema. So over here, it makes your skin red and itchy, common in children, but can occur at any age. And this person is 46 years. Okay, but it's very common in children, but it can also occur in the adult. Now, with the history of bronchial asthma, atopic dermatitis is the likely diagnosis. Remember, I told you that atopic dermatitis is the same as what? Eczema. And atopy simply means what? Allergic reaction or type 1 hypersensitivity. And this patient has a history of that. So with this history in mind, we can boldly say we are dealing with what? Eczema or atopic dermatitis or atopic dermatitis or eczema. So your answer here is A. So we have a 30-year-old woman who came to a doctor with complaints of menstruations that have been missing for 2 years after her second childbirth. So they've given you a clue. After her second, so that means it has to do with what? Delivery in a way, right? So now let's look at it. Now the childbirth was complicated by a massive bleeding. So all that we're looking at for is what? Complications of massive bleeding in child delivery. What can happen when you bleed too much or when you have PPH, postpartum hemorrhage? All right, so that is what you are looking at. Always look out for what is being given to you and look out for the possible what complication, because that is what the questions are always directing your mind to. Now, after giving birth, the woman started noticing hair loss and weight loss. The woman's body type is asthenic, her external genitalia are hypoplastic, the cervix is cylindrical, uterus is small and painless, uterine appendage cannot be detected. What is the most likely diagnosis? So again, we are looking at for what? For what could be the reason why there's hair loss, there's weight loss after massive bleeding in childbearing, and that is what we call Sheehan's syndrome or postpartum pituitary gland necrosis. Postpartum pituitary gland necrosis, which simply means that postpartum means mother who gives birth to an infant. Pituitary means that the gland at the base of the brain, all right, which is called the pituitary gland. And then necrosis means that death. So that means there's a death of this pituitary gland, as simple as that. And this normally occurs when you have massive bleeding when you give birth. That is one of the major causes of it. Now, when do we suspect people with Sheehan syndrome? So we suspect people with Sheehan syndrome when one, they fail to lactate after giving birth. Not immediately, because normally it's normal for you to not lactate, especially within 2 to 3 days of giving birth. It's normal. All right. But we'll tell you what to do and everything. But if still, after some time, mother is not able to lactate, then you are looking out for what? Sheehan syndrome. Then there's also absent menstruation. You know, menstruation partly is because when it's absent is because there's what? Prolactin deficiency. Prolactin deficiency, which is produced by the pituitary gland. All right. Then sometimes too, there are some features of hypopituitarism. which means that there is a hypothyroidism, and then there's what cortisol deficiency. And again, that one depends on the extent of the necrosis. So these and many others are the reasons why we are saying that this woman is suffering from what we call Sheehan syndrome or pituitary amenorrhea. So your answer here is B. A 34-year-old man fell ill 3 days after an overexposure to cold. Again, what could be the reason why you fall ill after exposure to cold? So anytime Krok gives you something, look out for the complication. As simple as that. So that means that whatever I can talk about over here has to do with what? With cold, isn't it? Now he complains of fever, so there's infection. There is general weakness, sweating, and cough. Again, respiratory tract infection is in play. So that's the organ to look out for, respiratory tract infection. Now the cough was initially dry. Now when cough are dry, normally you're talking about the upper respiratory system. But when cough is or there is sputum production, okay, or when the cough is wet or the cough is moist, you are looking at lower respiratory tract infection. So as an assignment, go and look for the difference, or from what point do we say we are having lower respiratory tract infection, and from what organs upwards or structures upwards do we say is an upper respiratory tract infection. So please, that's an assignment for you. So let me know in the comment section. All right. Now, the cough was initially dry, but within the last 24 hours, a small amount of rusty sputum was produced. What it means is that the upper respiratory infection, which was initially dry, has now become moist, or there's now what sputum production, which means we are now looking at the lower respiratory tract infection. Now, objectively, examination detects herpes on the lips. These are some small sores, okay, around the lips. Again, it tells us some form of infection. Now, percussion reveals a dull sound on the lower pulmonary lobes. If you can remember, I told you that when you have a dull sound on auscultation, one of the things you're looking at for is what? Either there is fluid there or there's what? Consolidation. And consolidation simply means pneumonia, or one of the major causes of consolidation is what? Pneumonia. Alright. So if you have all these things at the back of your mind, I mean, it helps you to take some things out of the options. Now again, auscultation detects bronchial breathing. Normally, the normal breathing is vesicular. When we're having what? Bronchial breathing and tachycardia. No changes were detected in the organs of the abdominal cavity. What is the most likely cause in this case? All right. So I've already explained. So this is an overexposure to cold. And what happens when you get cold air inhaled is that it will trigger what we call excessive mucus production. Okay, because the cold has a specific temperature. The nostrils or the nose, let me put it that way, has a specific temperature you need to have. Now, when you are overexposed to cold, what happens is that it will trigger mucus production. And unfortunately, it is this excessive mucus production that traps bacteria, viruses, and fungi to develop, leading to an upper respiratory tract infection. And eventually, it will lead to lower respiratory tract infection if not managed promptly. And again, percussion dullness increases the probability of what? Pneumonia. But again, its absence does not also exclude pneumonia. So that is what we are looking at in this question. Now, the color, the amount, the consistency, and odor are also helpful in identifying which organism could be the cause. And that is why I brought this diagram here to help you. So when you have a rusty sputum production, you're basically looking at for what? Streptococcal pneumonia. If you have a purulent sputum, we're looking at for what? Staphylococcus aureus. If it is green, Pseudomonas. If it is red currant jelly sputum, Klebsiella pneumonia. Klebsiella pneumonia. So again, this question tells us that we are definitely dealing with streptococcal pneumonia. Streptococcal pneumonia. Streptococcal pneumonia. And pneumonia per classification, we have different classification for it. It can be by the organism that is causing it. It can be by the area it is being affected. It can also be by location, okay, whether it is acquired from the hospital or acquired from home. All of these are all forms of what? Classification. They are all forms of classification. Now, the question tells us that there is what? Percussion reveals a dull sound in the lower pulmonary lobes. The lower pulmonary lobes. That tells you that we could be dealing with what we call what? A lobar pneumonia. So the lobes, so lobar pneumonia, lobar pneumonia, lobar pneumonia. Another term for lobar pneumonia is what we call the Krupper's pneumonia. The Krupper's pneumonia. The Krupper's pneumonia. All right, and that's over here. Our answer will be E, Krupper's pneumonia. We'll talk about, and again, Krupper's pneumonia could also, because normally it is community acquired infection, mostly community acquired. Okay, community acquired infection. And nosocomial means, or in a way, it also means hospital acquired infection or hospital acquired pneumonia. Okay, so this question, it can either be community acquired or Krupper's pneumonia. But I think Krupper's is more appropriate in this question than community acquired focal pneumonia. So maybe the focal make it a bit, different. Focal also means that at a particular region. All right. So E will be our answer in this scenario. So we have a 65-year-old patient who was prescribed, pharmacotherapy. That's ramipril, atorvastatin, amlodipine, acetylsalicylic acid, mesoprolol, for essential hypertension with concomitant ischemic heart disease. So if I were you, look out for the groups of these drugs or these medications. It helps you a lot. And normally people with hypertension, we put them on some of these medication. But again, you have to also be looking at a lot of things before you can put them on all of these kind of medication. Now, this patient already has a heart issue, probably caused by the hypertension. All right, or the hypertension. No, it's hypertension that can cause ischemic heart disease, not ischemic heart disease causing hypertension. Yeah, normally the hypertension that causes ischemic heart disease. So in this case, that is, I think, what it is. I trying to be corrected anyways. Now, 2 weeks later, he consulted a doctor about a dry cough. Now, don't forget, this dry cough is not really about it being upper respiratory tract infection or lower respiratory tract infection. It's rather about a particular medication in this question that is causing the dry cough. Because some of the side effects of the drugs, one of them is to cause cough. Now, examination detects no sign of acute respiratory viral infection. Again, it helps you to rule out upper respiratory tract infection, like I said earlier. Now, a side effect of, so they've told you, a side effect of ramipril is suspected. So what group of drug is this ramipril? What group of drug is this ramipril? So what drug can be used to replace ramipril in the treatment plan? So you need to know the group of drug it is, and of course its function. And now look at the option that we have and see which other drug can perform similar function to get the desired result. Similar function to get the desired result. Now, the That drug is an ACE inhibitor or angiotensin converting enzyme inhibitor, which is the ramipril, angiotensin converting enzyme inhibitor. Now, I just put the diagram to just illustrate to you how it, or the pathogenesis or pathophysiology of this drug, how it works, the mechanism of action. All right, so it works by converting angiotensinogen, or basically when there is low blood, what the body does is that it stimulates the juxtacoronary apparatus to release what we call renin. This renin will convert angiotensinogen, which is produced by the liver. Okay, so renin will convert this to angiotensin 1 and this angiotensin 1 is further converted to angiotensin 2 by the ACE enzyme or the angiotensin converting enzyme. Then from angiotensin 2, it now increases blood pressure. So that is how it works. So when we say we have an ACE inhibitor, what it means is that we are trying to inhibit this ACE enzyme or this angiotensin converting enzyme. So what it means is that when this enzyme is inhibited, it will not convert angiotensin 1 to angiotensin 2, and eventually it will lead to what decrease of blood pressure. And don't forget, patients having what hypertension, that means blood pressure is already high, so you don't want to increase the blood pressure, but rather you want to what decrease the blood pressure. So that is how this angiotensin converting enzyme inhibitor works. It works by blocking the enzyme for converting angiotensin 1 to angiotensin 2. That is how it works. Now, among these drugs, you have to look for another drug that is able to reduce or prevent this angiotensin 2 from working. And what enzyme is that? Or what drug could it be? So, the drug that we're going to use will be a drug that will block the receptors. Yes, receptors. Because without receptors, enzymes don't work. Without receptors, enzymes don't work. Without receptors, enzymes don't work. So that is what we're going to use. So that's what we call angiotensin converted enzyme receptors. Let me put it that way. So that will prevent, or we call them ARBs. ARBs. That's angiotensin 2 receptor blockers. Angiotensin 2 receptor blockers. So it will block the receptors here. That will now convert that will be loving this enzyme. It will block the receptors. So that will be the work of this drug called angiotensin 2 receptor blocker. So again, it will not convert it, but it's performing the same function in a way, just that it's not using the enzyme, but it's using the receptors, and that drug is called valsartan. That drug is called valsartan. So the answer here is what valsartan. That is what E, valsartan. Yeah, so that's just simple. So this is just some of the ACE or angiotensin inhibitors. What they do. This is what they do. The functions on the kidney, function on the adrenal cortex, the brain, the vascular system. Okay, so the RAS system. That's what the RAS system does. This is what they do. The RAS system, the renin angiotensin aldosterone system. This is what they do. So if you don't know what the RAS system is, this is simply the RAS system. This whole diagram is the RAS system. So I believe it will make sense. All right. Now, 2 weeks after a case of tonsillitis, again, you're looking out for what? Yes, complication of tonsillitis. For those of you who have been following me, you will know that tonsillitis can lead to heart problem, it can lead to kidney issues. So either it's a heart or a kidney problem, as simple as that. So let's continue to see what it will happen. So after a case of tonsillitis, a 29-year-old patient noticed facial edema. Oh, there is weakness and there is decreased work capacity. Gradually, he developed shortness of breath. There is leg edema and lumbar edema. And again, edema also has things you have to be looking out for, or organs to always be looking out for. So if you have an edema, you're looking at the problem of the heart, you're looking at a problem of the kidneys, a problem of the liver, and even a problem of the GIT. So these are the areas. So you always read the question again to help you know which problem they are talking about. As simple as that. So now let's continue. His skin is pale, heart sounds are weakened. He has hydrothorax. You remember hydrothorax? Fluid accumulation in the pleural cavities occurring at one side. Now there's anasaka, simply means generalized body swelling. Generalized body swelling. Blood pressure is 150/100. Clinical urinalysis shows the following. Look at the following. So there is specific gravity, proteins, erythrocytes, hyaline cast. What is the provisional diagnosis? So all of these urinalysis shouldn't be found, especially the proteins, the erythrocyte, and the cast should not be found in blood. Sorry, in the urine. Now we are seeing it. What it means is that the kidney is under attack. The kidney is under attack. The kidney is not able to get rid of the fluid from the system, and as a result, the lungs, the heart are all endangered. They are all endangered. So if you look at it, now this is simply a condition we called post-streptococcal glomerulonephritis. Post-streptococcal. Don't forget, tonsillitis is caused by what? Strep. It's called by what? Strep. Or group A beta hemolytic streptococcus. That is the organism that causes tonsillitis. So post-strep glomerulonephritis. As simple as that. As simple as that. So that's why you're over here. So over here, this a typical tonsillitis on your left of the screen. The left of your screen, this side. All right. Look at this. Everything is fine. But over here, we are having what? A problem over there. Yeah. So if you get tonsillitis and later on you're having abnormal kidney function test or your analysis are not good, we are looking at for what? Acute glomerulonephritis. That's post-streptococcal. So your answer here is what? Is A, acute glomerulonephritis. But the right answer is what? Post-streptococcal glomerulonephritis, which is A. Now, during co-production, the concentration of dust in the air of the working area has been for many years exceeding the maximum permissible concentration by 4 to 8 times. What disease is most likely to develop among the workers in this industry as a result? So this is just coke production. So in coke production, what is the most important thing in coke production? That's what we're looking at for. And for coke production, the thing that you look at for more or that are a lot is coal. COAL, coal dust. So you see a lot of coal dust. And you have coal dust, we are simply saying you have the what? Anthracosis. If the thing that is causing the pneumoconiosis is coal or is smoke, we call it what? Anthracosis. Anthracosis. Over here, we are dealing with what? Anthracosis. Anthracosis. So your answer here is what is A. But what is bichinosis? It's simply caused by what? Cotton dust. Cotton dust. Cotton dust. Then asbestosis. Again, asbestos fibers. Silicosis. Silica. Then siderosis or Welder's disease is caused by what? A bit of what? Silica, and then some sand, quartz, and many other types of what? Rocks. So that's what siderosis, and I think even lead. All right. So over here, your answer is what is A. A 14-year-old girl. Second, let me see what is happening over here. Okay. So a 14-year-old girl is being examined by a pediatrician. Objectively, she has, this is tall, a tall stature, asthenic body type, striae on the skin of abdomen, and blue sclera. She was diagnosed with scoliotic posture and chest deformity. She has hypermobile joints. Her fingers and arms are long. Cardiac ultrasound scan visualizes a mitral valve prolapse. What is the most likely cause of her tall stature? Tall stature. So for tall stature, you're either looking at what, a Marfan syndrome or a Klinefelter syndrome. Marfan syndrome or Klinefelter syndrome. But in Klinefelter syndrome, it occurs in a boy, basically. The other thing occurs in a boy. So over here, very, very tall guy. But it occurs in a boy. But over here, they're saying like a 14-year-old girl. So again, it rules out Klinefelter syndrome. What would be the most obvious now would be what? Marfan syndrome. Marfan syndrome, which is here. So that's Marfan syndrome. Look at the chest deformity they mentioned. So look at it. These are the chest deformity. So this is the first. Where's my? So over here we have the what's called the indented breastbone or pectus excavatum. Then look at over here, protruding breastbone. So pectus carinatum. So that is the chest deformity they're talking about over here. And again, unfortunately, they have that kind of scoliotic posture. Now, this is a symbol to let you know, or a mnemonic for Marfan syndrome. So if you see these things, then you're looking at what a Marfan syndrome. One is the mitral valve prolapse, which was mentioned in the question. So ultrasound scan visualizes what? Mitral valve prolapse. Mitral valve prolapse. The rest are there: aortic aneurysm, retinal detachment, and so on and so forth. So again, we are dealing with what? A Marfan syndrome. So your answer here is D. Is D. 42-year-old man is a minor, all right, was freed after 12 hours spent under the rubble. So it's like there is something that has hit him down, all right, for 12 good hours. For 12 good hours. Now his both lower legs and feet are pale. Pale means that it's anemic. Blood flow to the area is reducing or has reduced. They went on to say there's no pulsation. That means blood flow there is completely disconnected. No sensitivity. So nerves, no passive movement in those areas, in the joint, nothing. He was hospitalized with tourniquet applied to both limbs. What urgent first aid must be in this case to prevent myoglobinuria and acute kidney failure? So normally when muscles are broken down as a result of accident, all right, these muscles called myoglobin can enter into the kidneys, all right. When they enter into the kidney, you start seeing them in your urine. It could destroy the kidney, because the kidney will be overworking, and that can easily lead to acute kidney failure. So if you release the tourniquet, what it means that the broken muscles in the lower extremities will all of them start coming up, okay, or they will start spreading into the blood. And what it does is that the kidney will have to filter all those things out, which will put a lot of work on the kidneys, and eventually it will lead to what? Acute kidney failure. So to prevent that, we'll continue to keep the tourniquet on, because after 12 hours, that part is already gone. No pulse, no sensitivity, no passive movement. It means that that area is already gone. So all that you have to do is to amputate above it. Yes, you have to amputate the limbs above the area of the tourniquet. And that's what we'll be doing in this patient. So that's just the diagram. All right, no pulse is there. So what here we're looking at what? Do not remove the tourniquet. All right, amputate the limbs above the tourniquet. So that's just it. Amputate above it. Amputate above it. So the answer is D. Now, 26-year-old man who has been suffering from rheumatoid arthritis for 5 months has edemas at her elbow, radiocarpal, the knee, and the ankle joint, and rheumatoid nodules in the area of her elbow joint. Complete blood count shows ESR of 57, which shows that there's a chronic condition going on. Cirrhotic protein is plus. X-ray of the joint reveals marked osteoporosis. So that means the bones are porous or is weakened, what medicine will be used as the basic therapy in this case? So normally people suffering from rheumatoid arthritis with how do you call it? With osteoporosis or with bone deformities, what we normally use is what we call the CDMARDS. CDMARDS, which simply stands for conventional disease modifying anti-rheumatoid or anti-rheumatic drugs. Again, conventional disease modifying anti-rheumatic drugs. Okay, and of them, one of the examples is methotrexate. One of the examples is methotrexate. Methotrexate. The others are leflunomide, hydrochloroquine, sulfasalazine, and so on. These are the other drugs in the same group. These are the other drugs in the same group. Over here, we will be looking at what at methotrexate. So normally people suffering from rheumatoid arthritis, that is the drug we give to them. The CDMARDS. CDMARDS. Again, conventional disease modifying anti-rheumatic drugs. All right. And that brings us to the end of the first session. If you enjoyed it, let me know in the comment section. Like, share, and tell people about it. So see you in the next presentation.